Okay. All right. So I guess I think most people know who I am, so I can just go ahead and get started. For those of you who don't know, I'm Jen Heim. I'm one of the movement disorder neurologists at Phoenix Children's Hospital, and I wanted to talk today about early diagnosis of cerebral palsy. So this has been kind of a big push in the field to identify CP earlier, and it's been a big push of like the AAC-PDM, for example. And this is to, really the goal is to have earlier access to effective therapies for these kids. You have to identify what the problem is before you can start to work towards, solutions. So it is, it's something that we're really trying to push towards the early and accurate diagnosis of cerebral palsy. So to kind of illustrate my point, these are my learning objectives, how much you can read here. So, incorporate, new abilities, strategies to diagnose, manage, and treat, analyze and apply the latest research, implement improvements in, pediatric healthcare, safety issues for various pediatric neurologic conditions, counsel patients and families on short-term, long-term prognoses, treatment options, translate knowledge into practice improvement with a goal of improving outcomes of the patients with pediatric neurologic and psychiatric disorders, and also to improve patient care outcomes for children with complex neurologic conditions by integrating up-to-date accurate information and research to defend the best course of action. And I have no financial disclosures. So I'm starting out with an example composite patient. So this is kind of a composite of real life patients that I have seen, all de-identified, obviously, that kind of illustrates a lot of the points that I'm making in this talk. So the patient's a 9-month-old male, and he's been referred to pediatric movement disorder clinic due to abnormal movements of his right arm and his right leg. So his parents first noticed abnormal movements involving his right arm and right foot when he was about 4 months old, at which time he began to show a left-hand preference. And they noticed that when he was playing with toys, he would only use his left hand, and he will frequently use his left hand to quote unquote help his right hand. And he tends to hold his right arm extended and internally rotated. Only rarely opens his right hand, so he tends to be pretty fisted in his right hand. And when he does, they notice that his right thumb appears very tight and abducted, and he's not able to pick up objects consistently with his right hand. And although the muscle tightness and asymmetry are more apparent in his arms than his legs, they do notice that he typically only will bear weight reliably on his left leg, not on the right leg. Okay. And when he's placed in a baby walker, he will appear to drag his right leg. His foot seems internally rotated. He's not yet taking alternating steps. They do not notice any facial asymmetry. He's not yet able to sit independently, but he is able to sit with support. And he will sometimes try to tripod sit, but tends to fall to his right side. And when he's placed in a prone position, he's able to push his torso up off the bed using his left arm, but his right arm will remain flexed and his right hand is fisted. So they also notice that he's able to roll to his left side, but not to his right side. They notice he's a good eater. He has no difficulty with feeds or with gaining weight. Okay, so a lot of things, for folks who work in the neurosciences, kind of the thing that really jumps out is the asymmetries, right? So there's a whole list of asymmetries, but you could see how some of them can be quite subtle, and you really have to listen to the parents, and get their input and carefully observe the child to pick up on some of these. Okay. Some further information about this patient. So they do not have any concerns about his hearing or his vision. He has been referred to physical therapy, and they just had their intake appointment, and he's scheduled to receive once weekly physical therapy. And he has no history of seizures or other abnormal involuntary movements. Okay, so like I mentioned in the previous slide, sometimes these asymmetries, they can be they can be a little subtle and difficult to recognize. Other things that I mentioned in there too are just the basic motor milestones, which we have drilled into us. Those of us who had the pediatric training, like that's one of the core things that they teach you is milestones and the range of what's considered normal. And I stole this this nice little table here from the Hammersmith Infant Neurologic Examination, which we'll talk a little more about later in the talk. But that can be another clue in that there may be a diagnosis of cerebral palsy ultimately here, is if they're missing milestones, or if their milestones are very delayed, or if you're noting a lot of those asymmetries. So to take a pause to kind of define our terms. So what is cerebral palsy? And believe it or not, this is sometimes debated when we have our movement disorder SIGs and annual meetings, especially since we now have so much more information about the genetics involved in it. Is that obliging us to kind of revise our definition of what cerebral palsy means? That's another area of active discussion. But cerebral palsy refers to a group of neurologic disorders and that appear in infancy or early childhood and permanently affect body movement and muscle coordination. And it's caused by damage to or abnormalities inside the developing brain that disrupt the brain's ability to control movement and to maintain posture and balance. So the term cerebral palsy, the cerebral part refers to the brain. The palsy refers to the loss or impairment of the motor function. Okay, so it comes from the brain. It starts in infancy. It's non-progressive, and it affects movement. Are some of the basic takeaways for this definition. In some cases, the areas of the brain involved in the muscle movement do not develop as expected during fetal growth, and in others, the damage is a result of injury to the brain either before, during, or after birth. And in each case, the damage is not reversible, and the disabilities that result are permanent. Okay, now that doesn't mean that they can't make progress, that they can't, gain milestones, but typically it means that they're not going to catch up to their age-matched peers in that regard. And CP is the leading cause of one of the leading cause of childhood disabilities in the U.S., but it doesn't always cause profound disabilities, and that's important to remember as well. So someone with mild CP may not need any assistance, or they may have only slight problems, such as difficulty walking. I've had patients before who were, like basketball players, and they come to see us just because they have a little tightness in their hand, and that makes it a little difficult for them to, be agile when they dribble the basketball. So they can be very mildly affected. While a person with severe cerebral palsy, they might need special equipment, they might need lifelong care. They might be completely dependent for all their activities of daily living. The disorder is not progressive, meaning that it does not get worse over time, and some symptoms may even change as the child gets older. And there is no cure for cerebral palsy, but supportive treatments, medications, and surgery in some cases can help many individuals improve their motor skills and their ability to communicate with the world. And this is the NIH, the National Institute for Neurologic Disorders and Stroke definition. So who is at risk for cerebral palsy and what causes it? So it's caused by abnormal development of part of the brain or by damage to parts of the brain that control movement specifically. And that damage can occur before, during, or shortly after birth. So the majority of people have congenital cerebral palsy, meaning they're born with it, although it may not be detected until months or years later. And then possible causes of congenital CP, they include genetic abnormalities, congenital brain malformations, maternal infections or fevers, or fetal injuries. And then a small number of individuals have acquired CP, which means that the disorder begins after birth. So some causes of acquired CP, that includes brain damage very early in life, brain infections, problems with blood flow to the brain, strokes, head injuries. In many cases, the cause of cerebral palsy is unknown. All right, and then how do we diagnose cerebral palsy? So the diagnosis of CP typically begins with a detailed medical history and physical exam. That's always the most important, detailed medical history, physical exam. Historically, cerebral palsy has been diagnosed between like 12 to 24 months of age. The consensus previously was to take kind of more of like a wait and see approach. But more recently, we can diagnose cerebral palsy even before 6 months corrected gestational age with, a fair degree of sensitivity and specificity. Okay, so what is early detection? Why is it important? So early diagnosis and detection, it often opens the door for patients to participate in the early interventions for cerebral palsy specifically. So if you have to identify that there's a problem before you can work towards, getting them the appropriate treatments for that problem. So the early interventions, they allow patients to take full advantage of neuroplasticity to improve future function. So and the earlier that you start, generally speaking, the better. And then evidence also suggests that early diagnosis has benefits for preventing future complications and also improving caregiver well-being, which is, very, very important as well. That we're looking after the caregivers, okay, because they're with these kids, 24/7, and a lot of them do require a lot of care, especially early on, and sometimes for years to come. So it's really important that we be supporting them in any way we can. There are recommendations for infants younger than 5 months of age corrected, and for infants older than 5 months of age. Okay. And cerebral palsy specific early intervention, what it does is it uses intense motor learning task specific approaches, okay, plus environmental enrichment that optimizes the natural neuroplasticity and improves the children's motor and cognitive outcomes. So the goal and what they're trying to do is to try to harness and take advantage of that natural neuroplasticity in these young children and harness that with these, motor learning task specific approaches, okay, so that they can, maximize their potential. If you do, a specific task approach, physical therapy in a 6 months old, they're their brain's ability to kind of rewire itself is going to be much, much more robust than, let's say, an 80-year-old who's had a stroke in the same area because of that neuroplasticity. So early regular monitoring and treatment for the known musculoskeletal complications of cerebral palsy can prevent the onset, or at least delay the onset of hip dislocation, scoliosis, and contractures. Okay, so that's an important thing to keep in mind, because the muscles are not designed to be, in many cases, very tight like that all the time. That can create a lot of imbalances that can cause a lot of orthopedic problems, and that if we don't address them, they can just get worse over time. So that's why it's really important. So parents experience also more depression and stress when they're dissatisfied with the diagnostic process, and families prefer early diagnosis followed by early intervention and parent-to-parent support. Even though it's often a difficult diagnosis for parents to receive, that your child has cerebral palsy, when surveyed, they at least say that they much prefer the early diagnosis and then to get into the early intervention treatment plan. And that also opens up for them this network of support that can be really, really therapeutic for them and helpful. Okay, and then I just wanted to review some of the evidence for the early diagnosis. So this was a review that was published, the early accurate diagnosis, early intervention in cerebral palsy in JAMA Pediatrics. And then this is the AACPDM. So that's an organization devoted to cerebral palsy. Okay. This is one of their real goals and things that they are pushing for. They talk a lot about it at their national conferences. So they developed a care pathway. This is, all publicly available on their website. The target, the target clinical providers are neurologists, pediatricians, neonatologists, pediatric rehabilitation specialists and physiatrists, general practitioners, neuroradiologists, physiotherapists, occupational therapists, speech therapists, nurses, and early educators. And then the target population is infants with CP and their parents. Okay, and this is kind of the algorithm that they refer to. Again, this is from that JAMA Pediatrics article. And they developed kind of a flow sheet for evidence-informed care for the early diagnosis of cerebral palsy, okay? And they first stratify like the risk factors, because there are a number of things that confer, higher risk for cerebral palsy, like being preterm, evidence of, encephalopathy, history of neurologic risk factors like birth defects, intrauterine growth restriction, parent-identified concerns, unable to sit at 9 months, or hand asymmetry. So this asymmetries, again, in neurology, we like symmetry, and the asymmetries, if they are there, can be a big clue in. And then the risk concerns warrant investigation for CP. And then they have separate pathways based on their corrected age. Okay, and the green and the yellow, they indicate the strength of the evidence. The green is more strong evidence. The yellow is weaker evidence. And it kind of gives you a care pathway as to how to do this in a systematic way. So the Heim, in particular, that's referring to the Hammersmith Infant Neurologic Examination. And that is something that is scored, and based on what your score is, you can determine like what is your likelihood of ultimately having a cerebral palsy diagnosis. Okay. And there's a lot of tools that they refer to in this diagram. Again, first of all, the Heim, MRI, the Pretzel General Movements Assessments. So that's another standardized validated assessment of movements that can help be very predictive. And then there's the test of infant motor performance, or the TIMP, the Development Assessment of Youth and Children, or the DACY, the Alberta Infant Motor Scale, or the AIMS, Neurosensory Motor Development Assessment, NSMDA, and then the Standardized Motor Assessment, or the MAI. Okay, and this is a screenshot of some of the pages of the Heim. So the Heim, you do have to be get some training to administer it, but there are organizations that regularly offer training sessions because they really want to get more people, trained in how to do this. Okay, I was lucky enough, I got to go to Atlanta to participate in one of the training sessions at Emory, and they had actual real live babies to do the training on. And there's a number of our therapists here at Phoenix Children's who have done the training as well. But basically, you're looking at you're looking at a combination of the global score, number of asymmetries. You also do a behavioral score, and you take into account the patient's chronological age, but also their gestational age. And then you score these. And, based on the scores and number of asymmetries, you can kind of stratify their risk for determining their risk for cerebral palsy. And as you can see, there's a lot of, it's quite long. It's like 4 pages long, but if you get if you do it quite a bit, you can complete it fairly quickly. Okay. And then obviously MRI brain is also important and tool to make the diagnosis. It's not part of the clinical definition though of cerebral palsy, but it can be helpful in making your diagnosis. So what is the role of the MRI brain? So in patients who are considered at high risk for cerebral palsy, it can be helpful to determine the cause of the cerebral palsy. And then depending on the disease process, it can be sometimes difficult to interpret in young infants, for example, under the age of 2 years, due to the incomplete myelination, which makes the brain structures very difficult to see. Sometimes it's if there's very gross abnormalities, if there's severe HIE or there's a big stroke, it can be easier to interpret even in very, very young children. So if you are for example, the first case that I mentioned, seeing so many asymmetries, even in a 9-month-old male, not 2 years old, and theoretically not totally myelinated yet, but still worthwhile to do an MRI at a younger age because of all the clear asymmetries. And I believe on that, that patient, we did actually see surprise, a left MCA stroke and some encephalomalacia. And it was useful even at that young age. But in a lot of kids, it can be a little difficult to interpret until they're 2 years due to that incomplete myelination. And then the MRI is abnormal in greater than 80% of children who are diagnosed with cerebral palsy, but in 20% of them, it will be interpreted as normal. So there's a significant minority of patients who have normal MRI brain, and that should raise suspicion for a possible genetic cause of the cerebral palsy, which we'll talk about a little bit later. So most common abnormal MRI findings in children who have cerebral palsy are white matter injuries, 50%, gray matter injuries, 20%, malformations in 11%, and then approximately, according to this study here in Frontiers in Neurology, approximately 10% will have the normal MRI findings. Okay, and these are some examples of different MRI brain findings that you can see in patients who have who ultimately go on to be diagnosed with cerebral palsy. So, in letter A, you can see there's maldevelopment, frontal parietal polymicrogyria. That's a 2-year-old girl with CP, GM left affecting the left side, GMFCS1. In B, you can see there's predominantly white matter injury or periventricular leukomalacia, or PVL. That's a very common finding that we will see, particularly in preterm infants. This particular girl is about 32 weeks gestational age. In letter C, there's predominant gray matter injury, mild basal ganglion thalamus lesion. So that was a 3-year-old girl who had a placental ablation, and because the injury is affecting the basal ganglia, she has more dyskinetic CP. Whoops. And in D, there's cerebellar atrophy, in a 26-week infant, and some other examples of PVL that you can see on some of the different sequences. But there's a wide variety of lesions that you can see that can contribute to cerebral palsy. And then what's the role of genetic testing? So as the genetic testing has become more widely available, we're now beginning to understand what an important role the genetics plays in many medical conditions previously thought to be acquired only, including cerebral palsy, but not only cerebral palsy. Okay, so there's a number of conditions to which this applies. And genetic testing of patients with cerebral palsy, it's contributed greatly to our understanding and can have significant benefits for individuals with cerebral palsy. Okay. And then, genetics has the potential to help guide treatment decisions and to anticipate the risk for other medical conditions, such as autism spectrum disorder or epilepsy, because we're finding that many of these genetic conditions, they don't just contribute to cerebral palsy, they don't just contribute to movement disorders, but they also can have other associated like epilepsy, or they can have, specific types of headaches, or they can have autism, learning disabilities, hearing loss that can be associated. And that can be really helpful if we can anticipate, problems before they become, very, very severe. Okay. And then here is a table. This is from Frontiers in Neurology paper for recommendations for genetic workup according to some neuroimaging findings. Okay. So if you see a pattern of maldevelopments, workup recommended for monogenic diseases, rule of thumb, disorders of cortical malformation, proliferation of migration, defects are genetic origin, whereas later defects such as organization or post-migrational defects like polymicrogyria can be genetic or non-genetic. And then for the predominantly white matter, predominantly gray matter injuries, for genetic vulnerability factors, defects leading to thrombophilia, or interfering with collagen formation, like some collagenopathies. The contribution, though, is low, thus check with the family history, whether there's a causative external factors that are missing. For miscellaneous monogenic diseases, indicators can be disorders of myelination, like hypomyelination, cerebral atrophy, cerebellar atrophy, hypoplastic corpus callosum. These are all kind of rather nonspecific, but they can be more common in children who have underlying genetic conditions. And then if you see the normal brain MRI for monogenic diseases before initiating the genetic testing, check on a child with good cognition and mild spastic or dyskinetic CP. Has the MRI been done before the age of 2 years? Has the spinal MRI been done? Consider a levodopa trial, because some of the genetic conditions, in particular the dopa responsive dystonia, they can be quite robustly responsive to certain medications like levodopa. Okay. So just to kind of wrap it all up, this was meant to be kind of an overview of the the push for early diagnosis, but just to really kind of drive home the point that with the current diagnostic tools that are available, it is possible to accurately diagnose cerebral palsy even before the age of 5 months. So that's been I think a major step forward in the field, that we can identify this so early. And then making early accurate diagnosis allows the infant with cerebral palsy to take, again, full advantage of that neuroplasticity and to access resources for children with neurodevelopmental disabilities. And then the combination of careful history and the physical exam, the MRI findings, the standardized assessment tools like the GMA and the Heim, and genetic testing, when appropriate, it can lead to better long-term outcomes for the people with cerebral palsy and their families. And that's ultimately what our goal is. And then some of the that begs the question, well, why don't we do this all the time? And I think there still exists a couple of barriers in terms of why this isn't like standard for every patient. I think one of them is a lot of these assessments, in particular the Heim and the GMA, they do require training. So you have to have either practitioners, physicians, NPs, PAs who are trained, or therapists. And most of the people who are getting trained in this are therapists, like physical therapists, occupational therapists, and they're kind of on the front lines because they're oftentimes working with these children week to week to week. I've gotten plenty of referrals from a PT or from a occupational therapist saying, I'm noticing some asymmetries like this, you should go see a neurologist to investigate this a little further. And sure enough, it turns out they're 100% right, and the child ends up getting diagnosed with cerebral palsy. But it does require time, taking out energy, and also the availability of these training programs in order to get trained. So I think that's one potential barrier. Other potential barrier is just time. We're all super busy all the time. We all have busy, clinic schedules, therapy schedules. So, when you're presented with this, several page long assessment that you have to do and look very carefully and score, it can seem a little, it can seem a little daunting when you have to fit that into an already busy, clinic schedule, other responsibilities. But oftentimes, and if you can, learn how to do it, you do get faster as you go along. But that is, time is always a consideration for all of this. Other barriers too, in particular with the genetic testing, is ease of access. It can get quite expensive, and I was somewhat disappointed recently to find out that for a lot of the commercial genetic testing companies, it's actually less expensive for families to pay out of pocket rather than to have their insurance company pay for it, and then they have to do a copay. It's often less expensive for them to just pay out of pocket right off the bat. And so that's, that's a topic for discussion, but also ease of interpreting these results once you get them. Because anybody who's ordered genetic testing, in particular genetic testing for, for cerebral palsy or for, lots of other neurologic conditions like epilepsy, for example, you're often presented with, so sometimes you get a very clear answer, say, oh, they have a pathogenic mutation in this gene that is known to be associated with autosomal dominant, hereditary spastic paraplegia, which is, just one example. But oftentimes, or maybe even more often, you get a bunch of variants of unknown significance, the dreaded VUS. And that can be kind of daunting, for people to kind of, work through and interpret, and also to discuss with families. So it can be really, really helpful if you have access, for example, to, genetic counselors. They can really help facilitate some of these discussions, or that you have access to robust, genetics departments that can help you facilitate some of these discussions with folks, in particular with families, and especially if there is a language barrier, because those can be kind of challenging. And I think we've all had, discussions like that. They can be quite challenging, try to, work with the families to interpret those results and what they mean. And I think that too, it's helpful. Oftentimes, if you can treat, or if you can test parents, that can be another useful tool to help distinguish if you do get those variants of unknown significance. Oftentimes, the genetic testing companies will test the parents for free, or they'll test family members for free, of charge, because that can really help you to interpret if a variant of unknown significance is likely to be pathogenic versus not. If the mutation is unique to the patient and is not inherited from either parent, or is a de novo mutation, then it's higher likelihood that that is responsible for the patient's condition, and as opposed to if they inherited it from one of their parents who is not affected, who does not have cerebral palsy in this case, then that's makes it much more likely that that is a benign variant, okay, or at least that there's decreased penetrance. So it can be really, really helpful, and I think that that can be another potential barrier that we can we'll have to try as a field to work to overcome, is access to these things, access to the training, having the time to actually do these. And I wanted to make a plug too for one of the things that we've been trying to implement here at Phoenix Children's Hospital, and I have to give a lot of credit to Michael Kruer and Jasmine Ng, who was one of the previous PM&R doctors, and all the wonderful therapists who work with us, and also Sheila, who helps coordinate this. In the past few years, we've had an early diagnostic cerebral palsy clinic that meets once a month, and we do it together, movement disorder neurology with PM&R, and together with occupational therapy, physical therapy together with the therapist, where we actually administer the Heim during the visit. And that can be kind of a nice gateway for these kids to have a one-stop shop. And it's just one afternoon. We schedule 4 patients. It's kind of a revolving door type of situation, and that's been I think really, really nice to have that access. And it would be wonderful if we could expand that a little bit, but I think that's I think it's a good start into getting these patients early access to diagnostic tools, and then hopefully to some of the therapies that are evidence-based. Okay, and I could go on and on about this this topic, but I wanted to leave some time at the end for questions. And yeah, so thank you everybody for your attention, and I'd be happy to take your questions.
That was excellent, Jen. I appreciate it very much. And my question is actually right on what you ended up on that early motor assessment cerebral palsy clinic. Can you talk a little bit about how people get into that? Is that an internal referral only, or can outside providers, pediatricians refer to that? How do people get into that? And what role do you see of that right now in your limited scope, and whether it could be expanded?
Yeah, so I think that it's usually your best bet for that clinic is to message, some of the people involved. And again, it's only 1/2 day per month. So what we did not want to do was to, kind of tap the fire hydrant, so to speak, because it's only 4 patients a month that we're seeing. But if you have someone that you think, hey, I have some concerns, like, that, composite patient I talked about at the very beginning, usually your best bet is if you message the folks from, either, movement disorder neurology or to, or one of the PM&R doctors in order to get into that clinic. And in the past, one of the coordinators, Sheila, would really help with making the schedule. Unfortunately, she's no longer in that role, but I believe it's kind of a work in progress how to create a nice pipeline into that. Sometimes we get referrals from like UCP, United Cerebral Palsy, children who are getting therapies there. I'm not sure if Michael is on this call. He might be able to speak more to if there's a direct referral to it. But for anybody who's on this call, I think if you reach out, if you have a patient that you think would benefit from being in this clinic, just to reach out directly to any of the movement disorder doctors, the PM&R doctors, because we all participate. We participate in this. So. Yeah, Mike, I don't know if Michael's on, if he has anything else to add about how to make referrals to this clinic. Doesn't sound like it, but and you can always, like I said, just message any of us, and we can hopefully work them in. But just be aware it does have very limited availability. So. Any other questions?
Hi, Jen. Thanks so much for a great overview on an important topic. So genetic testing continues to be a challenge. One, both getting it approved for the type of testing that you want to do, and then understanding what the best strategy is for the most revealing, least expensive genetic test to do. So for epilepsy, we would typically start with a dedicated gene panel unless we had a very high suspicion to confirm one particular epilepsy syndrome. But what's your strategy with CP? Since whole exome sequencing isn't usually available, is there a targeted gene panel that you would start with, or where do you start?
Yeah, it's a great question. Hopefully, someday I hope the insurance companies will see the light and realize that, whole exome sequencing is the most cost-effective way to, gene for gene, so to speak. It's the most cost-effective way to actually get you a diagnosis. But, that might be a bit far off, but we can dream, can't we? So usually my approach is, if I'm strongly suspecting that that there may be a genetic cause, usually I will start with If there's also some, concern for like autism, for example, or other developmental disabilities, insurance companies will cover. So things like Fragile X, chromosome microarray, those are relatively easy to do, and we can run them in-house. I will often, much like the epilepsy, revert to the gene panels. So companies like Invitae, companies like GeneDx. Usually those are kind of my go-tos, but they have cerebral palsy panels. They also have some that are a little more specific to different movement disorders. Like they have a spinocerebellar ataxia panel. They have a hereditary spastic paraplegia panel. And oftentimes sometimes you'll get an answer with those. You get a gene mutation that's clearly, pathogenic. In the majority of cases, not usually. I typically, and usually the only time I'll order like a single gene, very rarely am I, super confident in this patient has all the features and I'm going to order this, single gene. I think the longer that I've been doing this, I realize, I'm not as good at identifying each specific condition single gene as I think I am. So it's helps to cast a bit wider net. But the times that I will order single gene is if I have siblings, for example. I recently had a patient who has dopa responsive dystonia and has, it's a family of 4, and, 2 of the other siblings were having similar symptoms. So in that case, it was, relatively easy. And it turns out those 2 children also have the same gene mutation. But sometimes if, for example, we do the gene panel and that is either inconclusive or it's negative, and we, really do strongly suspect a genetic condition, then I will try to use that to make the case that the insurance company will cover like the whole exome sequencing, or refer them to geneticists in hopes that, because I believe some of the insurance companies, that might have a bearing on whether they cover it or not, as if it's ordered by an actual geneticist. But it's, it certainly is a challenge, not only with the, the access and the cost, but also with the, with the interpretation. And it can be, I think there's really a case to be made to, have genetic counselors kind of more widely available. Even like within each department. I know that some children's hospitals, they have, dedicated genetics counselors who spend, certain amount of time with each of the subspecialties. Like at CHOP, for example, they have a genetic counselor dedicated in neurology who splits their time kind of 50-50 between movement disorders and neuromuscular. And that's, wonderful resource to have, especially to have, facilitate some of these tough, conversations, like trying to talk through, what does a VUS mean, through a Arabic translator. That can be a challenging, conversation to for both sides to have the understanding. So, but that's kind of what my approach has been. Any other questions?
Thank you.
Okay. Well, thank you all so much. I appreciate your time and attention this morning. Everybody have a great week. Enjoy your Monday.
Thank you, Jen. That was